Go look in a mirror. Not a quick glance. Actually look. Study your face for 30 seconds with the kind of attention you'd give something that mattered. Look at where your hairline sits, how your ears are positioned, whether your eyes are perfectly level, whether one side of your jaw is the same as the other, whether your nose runs in a perfectly straight line from bridge to tip. Take your time. What you're seeing, and what almost nobody who does this exercise is prepared for, is asymmetry. Subtle in most cases, dramatic in some, but present in essentially everyone. Your face is not the same on both sides. It never has been. The version of you that exists in photographs that are accidentally mirrored looks subtly wrong to everyone who knows you, including you, because you've internalized a face that was never symmetrical to begin with. That's just the beginning, because the face is the visible example, the one you can check in a mirror right now. But the human body from the outside in, from skin to skeleton to organ arrangement, is full of structural variations, asymmetries, and configurations that medicine technically classifies as anomalous, but that affect such large proportions of the population that calling them deformities feels almost comedically dramatic. These aren't rare conditions. They're not things that happen to other people. They are, in many cases, features of normal human biology that most people carry entirely without knowing. The word deformity in the title is doing intentional, provocative work. The clinical language around structural variations in human anatomy often uses words like anomaly, variant, malformation, and deformity in ways that imply these are problems, departures from a correct baseline. But the baseline is messier than the language suggests. Evolution doesn't produce perfect templates. It produces variations, some of which affect function, and some of which are just different. The line between normal variation and deformity is often a matter of medical convention rather than biological reality. And the closer you look, the more that line blurs. Here is what most people are actually carrying around without any idea. Facial asymmetry first, because it deserves more than the mirror exercise, and because the degree to which this affects everyone is not well appreciated outside of the research literature. Studies measuring facial asymmetry across large populations consistently find that perfect bilateral symmetry. A face where the left half is a mirror image of the right essentially does not exist in nature. Every human face has some degree of asymmetry. The degree varies, with most people sitting in a moderate range that is noticeable when pointed out, but not immediately striking, and a smaller proportion of people having asymmetry significant enough that it's the first thing you notice in certain photographs or angles. The sources of facial asymmetry are multiple and interact during development. Genetic factors establish the initial template. Differential growth rates between the two sides of the developing face create variation during fetal development and childhood. Mechanical forces. How you sleep, habitual chewing patterns, dental occlusion, even which side you tend to rest your head on, influence bone remodeling over time. The jaw is particularly susceptible to these mechanical influences, which is why dentists and orthodontists spend so much time analyzing jaw symmetry, and why people who have had braces often have structural changes that can take years to fully stabilize. The brain, operating through a slight asymmetry in its own structure, also contributes to facial asymmetry through differential muscular expression. Most people have subtly stronger muscle tone on one side of the face, reflecting hemispheric dominance and habitual expression patterns. The side of your face that is slightly more developed muscularly is usually the more photogenic side from your own perspective, because it's the side that has been doing more expressive work and has had more blood flow and muscular development over your lifetime. When actors and models talk about their good side, they are describing this asymmetry through the lens of aesthetics rather than anatomy. When forensic scientists reconstruct facial identity from skeletal remains, asymmetry becomes a forensic tool. The specific pattern of facial asymmetry is individual enough to contribute to identification. Your asymmetry is, in a meaningful sense, yours specifically. Now move to the skeleton, because here the variations get more medically significant and more surprising. Spinal curvature is one of the most common hidden skeletal variations in the human population. The spine should, in an idealized human anatomy, have specific curvatures in specific planes. Lordotic curves in the cervical and lumbar regions, a kyphotic curve in the thoracic region, creating the S-shaped profile visible from the side in a healthy spine. In the frontal view, from behind, the spine should run essentially straight. It frequently does not. Mild scoliosis, lateral curvature of the spine, affects somewhere between 2 and 3% of the population by clinical measurement standards, but this figure reflects curves significant enough to be classified as scoliosis rather than normal variation. When you look at the distribution of spinal curvature across the entire population, the picture is different. Many more people have spinal curves that fall just below the clinical threshold, in the range that is technically normal but represents a departure from idealized symmetry. And then there is functional asymmetry, the kind produced by habitual posture, muscle imbalance, and the accumulated effect of years of spending more time in certain positions. The prevalence of true scoliosis is particularly striking in certain subgroups. Adolescent idiopathic scoliosis, the most common type, developing during the growth spurt of puberty for no clearly identified reason, affects girls at higher rates than boys and often goes undetected until it's found incidentally during examination for something else. The curve is painless in most cases, which is why people go undiagnosed. You can have a spine curving measurably to one side and have no symptom that would prompt you to investigate it. Cervical ribs are a fascinating example of variation that sits more cleanly in the unexpected structural feature category. The cervical spine, the neck, normally has 7 vertebrae, none of which have ribs attached to them. Ribs begin at the thoracic vertebrae in the chest. In roughly 1/2 to 1% of people, however, the 7th cervical vertebra has an extra rib. A cervical rib growing from the neck vertebra into the space above the first true rib. This is a vestigial structure. In the developmental sense, it represents the activation of rib-forming developmental pathways in a segment where they're normally suppressed. More distant vertebrate ancestors, and indeed fish, have something like ribs at every spinal level. The specific suppression of rib formation in the cervical region is a derived characteristic of mammals, and occasionally the suppression is incomplete in one individual, producing a cervical rib. The individual is carrying in their neck a structure their mammalian ancestors lost hundreds of millions of years ago. Most cervical ribs are asymptomatic and discovered only on X-rays taken for other reasons. Some, however, cause thoracic outlet syndrome, compression of the brachial plexus nerves, or subclavian blood vessels as they pass through the narrowed space created by the extra rib. Pain, numbness, tingling in the arm and hand, and vascular complications can result. The same structure that is invisible and harmless in one person causes significant medical problems in another, depending on its size and exact position. Lumbar ribs are the symmetric equivalent in the lower back, extra ribs developing from the first lumbar vertebra. And these occur at roughly similar frequency. Both cervical and lumbar ribs are typically diagnosed incidentally in people who had no idea they had them until an imaging study for something unrelated revealed them. Transitional vertebrae deserve mention here because they represent an entire category of spinal variation that affects a surprisingly large proportion of people. The junction between the lumbar spine and the sacrum is developmentally unstable in humans, and variations in exactly where this transition occurs are common. In sacralization, the lowest lumbar vertebra, L5, is partially or fully fused to the sacrum, behaving more like sacral bone than mobile lumbar vertebra. In lumbarization, the first sacral segment, S1, is partially separated from the rest of the sacrum, behaving more like a mobile lumbar vertebra. Studies suggest these transitional anomalies affect somewhere between 5 and 10% of the population. Most people with transitional vertebrae don't know they have them. The condition is often discovered when someone has lower back pain that prompts imaging, at which point the radiologist notes the variant. Whether the variant causes the pain or is simply an incidental finding is often genuinely unclear. The literature on whether transitional lumbosacral vertebrae predispose to back pain shows mixed results. You might have a sacralized L5 and never have back pain. By the way, if you want to go even deeper into the secret lives of ancient humans, I just launched a full course called The Secret Lives of Ancient Humans. 10 modules, 3+ hours of content covering everything we never talk about on YouTube. What they feared, how they communicated, what hunted them, and much more. Plus an exclusive PDF guide included. Link in the description. See you inside. You might have it and have chronic lower back issues. The structural variation exists across the population in both symptomatic and asymptomatic individuals, making it a statistically common feature rather than a rare anomaly. Move inside the skull, because here the structural variations become even more surprising and the proportion of people affected grows substantially. Accessory ossicles, small extra bones, are present in the skulls of a remarkable proportion of people. The skull, which looks like a simple dome from the outside, is actually a complex mosaic of multiple bones that fuse during development at specific sutures. The process of suture fusion is not perfectly standardized, and variations in how it proceeds can leave behind Wormian bones, small extra ossicles at the suture junctions that are entirely normal structurally but represent departures from the textbook skull. Wormian bones are present in some form in a significant minority of people and are visible on skull X-rays or CT scans. They have no clinical significance in most cases. They're just there, small extra bones in the skull that the standard anatomy diagram doesn't include. The Inca bone, or interparietal bone, is a variation where the back of the skull has an extra bone element, distinctly separated by a suture from the standard parietal and occipital bones. It has a name because it was notably common in ancient Andean populations, appearing in the skulls of pre-Columbian individuals at rates high enough to be a distinguishing feature of those skeletal collections. But it appears across human populations globally. The person sitting next to you on public transport could have an extra bone in the back of their skull, and there is no way to know it without imaging. Intracranial arachnoid cysts occupy a different but related category. These fluid-filled sacs, located in the spaces between the brain and the membranes surrounding it, are present in roughly 1 to 2% of the general population. Most are found incidentally on brain scans performed for headaches, head injuries, or routine screening. The cysts are typically asymptomatic. The person has no symptoms that would suggest anything is present. They just have a fluid-filled sac in their head that wasn't supposed to be there, going about their life, completely unaware. A small proportion of arachnoid cysts do cause problems. Depending on size and location, they can create pressure, headaches, seizures, or other neurological symptoms. But the majority are found, noted, monitored, and ultimately ignored because they're causing nothing and will probably continue causing nothing. The person who gets a brain scan after a car accident and is told, "You have an arachnoid cyst, we'll monitor it," often goes through a period of significant anxiety before learning that this finding in their specific case is likely clinically irrelevant. The scan that was supposed to check for injury instead revealed something that has probably been there for years. Organ asymmetry and the variations around it represent the deepest level of hidden structural variation in human anatomy. The heart sits on the left side. The liver fills the right upper abdomen. The stomach is on the left, the appendix on the lower right. This arrangement, technically called situs solitus, is the standard configuration. In roughly 1 in 10,000 people, the arrangement is completely mirrored, situs inversus, where every organ is on the opposite side from the standard. The heart is on the right, the liver on the left. Most people with situs inversus are entirely healthy. The mirrored arrangement is internally consistent, and everything works because all the relative relationships between organs are maintained, just flipped. They often don't know they have it until a doctor listens for heart sounds on the left and finds nothing, then checks the right and finds a heartbeat. The medical importance of situs inversus lies in the diagnostic confusion it creates. A person with situs inversus who develops appendicitis has pain in the lower left abdomen rather than the lower right, because that's where their appendix is. A heart attack affecting standard territory is misinterpreted on an EKG because the wave directions are reversed. The condition is both a medical curiosity and a practical diagnostic challenge because it systematically inverts the anatomical landmarks that medical diagnosis depends on. Between situs solitis and full situs inversus lies a spectrum of partial organ arrangements, situs ambiguus or heterotaxy, where some organs are in their standard positions and others are not. Heterotaxy is rarer and more clinically significant, often associated with complex cardiac malformations, and represents a developmental failure in the lateralization signals that normally specify which side each organ develops on. The developmental biology of left-right asymmetry is one of the more remarkable stories in embryology. The initial breaking of left-right symmetry in a developing embryo happens at the node, a small structure at the center of the embryo, where tiny hair-like structures called nodal cilia rotate in a specific direction, creating a directed fluid flow that moves signaling molecules to one side rather than the other. This physical flow triggers a cascade of molecular events that establishes left and right identity for all subsequent organ development. The rotation direction of nodal cilia is genetically determined and almost always consistent. When it's disrupted through mutation in cilia structure or function, randomization of left-right organ placement can result. Situs inversus is not disorder. It's a coherent alternative to the standard arrangement produced by a developmental program that ran consistently but in the mirror direction. The person living inside it functions normally. Their internal topology is the road less taken, and it makes essentially no difference to the journey. Supernumerary nipples, extra nipples, are present in roughly 1 to 5% of people, distributed along the milk lines that run from armpit to groin on both sides of the torso. In most cases, these are small, often mistaken for moles or birthmarks, and are only identified as nipple tissue when someone looks carefully or when the finding comes up medically. Mark Wahlberg has famously spoken about having a third nipple. He is not alone in any statistical sense. The developmental basis is the same principle as cervical ribs, a normally suppressed developmental pathway that is occasionally incompletely suppressed. Mammals have variable numbers of nipples across species, determined developmentally by the number of segments along the milk line where nipple formation is activated. Humans normally activate 2. Occasionally the regulation is off by 1, and a third appears. The third nipple is the mark of a developmental process that overshooted slightly, and it is common enough that it occupies its own medical term, polythelia, and its own clinical consideration set. The palmaris longus muscle is absent in roughly 15% of people. You can check right now, hold your hand palm up, touch your thumb to your pinky finger, and flex your wrist slightly. If a tendon pops up in the center of your wrist, you have a palmaris longus. If the center of your wrist is flat while the other tendons are visible, you don't have one, and you are in the company of roughly 1 in 7 people who also don't. The muscle is vestigial in humans, a remnant of a muscle that had more function in non-human primates for grip and wrist flexion. Human hands work entirely normally without it, which is why surgeons use the palmaris longus tendon as a graft source when they need tendon material for reconstructive procedures elsewhere. They can take it and the hand experiences no functional deficit. If you don't have one, you are not missing anything that affects how your hand works. You have simply already achieved, through developmental variation, what surgeons do deliberately in people who have one. The plantaris muscle in the leg is similarly absent in a significant minority of people. Estimates range from 7 to 20%, and similarly taken for reconstruction when present without any deficit created by its absence. The body has apparently decided, across these individuals, that certain ancestral structures are expendable, and the individuals are none the worse for it. Palatal tori, bony growths on the roof of the mouth, occur in anywhere from 10 to 30% of people depending on the population studied. If you run your tongue along the center of the roof of your mouth and feel a bony ridge or lump that wasn't what you expected, that's a palatal torus. It's benign, just extra bone growth in a location where bone doesn't normally form a prominence. But it can interfere with denture fitting and occasionally grows large enough to cause speech or swallowing issues. Most of the time it's just there, discovered by accident, causing nothing, noted, and forgotten. Mandibular tori are the same phenomenon on the inside of the lower jaw. bony growths on the lingual surface of the mandible in the floor of the mouth area. Prevalence estimates range considerably, but 5 to 40% across different populations, with rates varying substantially between ethnic groups. Same clinical picture, usually asymptomatic, discovered incidentally, occasionally problematic for dental procedures. The fact that something like a third of some populations have extra bone growing on their jaw or palate without knowing it, without it causing anything, without it ever coming up unless they see a dentist who mentions it, this is what the title means by hidden. These are not obscure conditions affecting a handful of people. They are common structural features of human anatomy that the standard picture of a normal body simply doesn't include. Coming back to where this started, the mirror, the face, the asymmetry you can see with your own eyes, the point of this entire exercise is not to generate medical anxiety. The structural variations described here, in the vast majority of people who have them, are clinically insignificant. They are doing nothing. They are just there, part of the specific configuration of your specific body, departures from an idealized template that exists nowhere in the actual world. The idealized human body, the one in anatomy textbooks, the one that serves as the reference against which variations are measured, is a statistical construct, an average of features, not a description of any real person. Real people have asymmetric faces and occasional extra ribs and fluid-filled spaces in their brains, and extra nipples and missing muscles and extra bones in their jaws and curved spines and hearts on the right side and every other configuration that falls outside the diagram. The diagram is the abstraction. You are the reality. And reality, it turns out, is considerably more varied, more surprising, and more structurally creative than any diagram has room to represent. The body you've been living in your whole life is stranger than you knew. That's not alarming. That's just accurate. And accurate is, if you're the kind of person who watched a video about hidden deformities to the end, considerably more interesting than comfortable.